I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Generic drugs save Americans billions of dollars a year. The FDA maintains that they're equivalent to their brand name counterparts. This is the People's Pharmacy with Terry and Joe Graydon.
Recent recalls of the blood pressure medicines losartan and valsartan have raised questions about generic drug quality. Where are generic drugs made, and how good are they?
Investigative journalist Catherine Eban has uncovered some shocking examples of fraud in the generic drug industry.
The FDA's position is we need all these generics, and they are permitting drugs that their investigators have deemed unsafe to be coming into the U.S.
Coming up on the People's Pharmacy, Ms. Eban's new book, Bottle of Lies.
First, the news.
In the People's Pharmacy Health headlines, people with very low levels of vitamin D are known to be at higher risk for developing type 2 diabetes. A new study has just shown, however, that vitamin D supplements don't alter the risk. The trial included 2,423 volunteers with pre-diabetes. During the 2.5 years of the study, they took either 4,000 international units of vitamin D3 or a placebo daily. There was no significant difference between the two groups with regard to the proportion of participants who developed diabetes. These findings confirm those from previous studies of vitamin D supplementation on the risk of diabetes. Other studies have shown that increased exercise and changes in diet can reduce the chance of a diabetes diagnosis by more than 50%. For someone with prediabetes, that approach seems to hold the greatest promise.
For decades, patients taking the anticoagulant warfarin, known by the brand name Coumadin, have been admonished to be very careful about consuming foods rich in vitamin K. That's because too much vitamin K could theoretically counteract the blood-thinning properties of warfarin. In practice, this meant that many patients avoided green leafy vegetables like kale, collards, spinach, or broccoli. Now, a new study from Montreal suggests that people would do better to eat more green leafy vegetables if they keep their vitamin K intake consistent. The trial involved 46 patients taking warfarin. They all had a history of difficulty maintaining consistent anticoagulant activity. For 6 months, half of the patients were given nutrition and cooking classes with a general focus on improving nutrition. They were the controls. The other half received nutrition and cooking classes focused on increasing the amounts of green vegetables and other vitamin K-rich foods in the diet. After 6 months, half of those who had increased their vitamin K intake had stable anticoagulant levels. In contrast, only 1/5 of the control group were able to achieve stability. Perhaps it's time for health professionals to counsel their patients taking warfarin to eat more green leafy vegetables rather than fewer and maintain a consistent intake of vitamin K daily.
Do you leave the television on in your bedroom overnight? Data from the sister study suggests you might want to turn it off. This study included healthy middle-aged women who were not shift workers. At the outset, they answered questionnaires about whether they slept without any light, used a nightlight, or slept with the room light or TV on. They were weighed and measured so that their body mass index could be calculated. 5 years later, they reported their own height, weight, waist, and hip measurements. Those who slept with the lights on were 17% more likely to have gained more than 10 pounds. These epidemiological data don't establish cause and effect. They do reinforce the idea that exposure to artificial light at night may contribute to obesity.
We recently reported on a large VA study using medical records of 150,000 veterans. It showed that people taking proton pump inhibitors to suppress stomach acid were at increased risk of premature death. Now, a randomized controlled trial involving more than 17,000 participants with heart disease and peripheral artery disease concludes that the PPI pantoprazole is not associated with any adverse events. There was one exception. People taking pantoprazole were 33% more susceptible to gastrointestinal infections. The authors note that the 3-year trial may not have lasted long enough to detect adverse outcomes such as cancer or fractures.
People with peripheral artery disease experience pain while walking. This is due to reduced blood flow to the muscles. Doctors often prescribe exercise as a treatment, but some people find that painful. A new study compared 2 supervised exercise sessions a week to half-hour hot water soaks 3 to 5 times weekly. Spa bathing was as effective as exercise for improving walking ability and controlling blood pressure. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Nearly 90% of the medications we take are now generic. The Food and Drug Administration has been assuring us for decades that generic drugs are just as good as their brand name counterparts. In other words, the antidepressant fluoxetine at $4 a month is supposed to be identical to Prozac at around $500 a month. The FDA maintains there's no reason to spend a lot of money on a brand-name medicine once they've approved a generic. Insurance companies love generic drugs because they save so much money. Is the quality always the same?
To help us sort through the complicated world of generic drugs, we turn to Katherine Eban. She's an investigative journalist, a contributor to Fortune magazine, and an Andrew Carnegie Fellow. She's author of Dangerous Doses, a true story of cops, counterfeiters, and the contamination of America's drug supply. Her new book is Bottle of Lies, the inside story of the generic drug boom.
Welcome back to the People's Pharmacy, Katherine Eban.
It's great to be back.
Katherine, we first spoke to you 14 years ago, if you can believe that. It was your book, Dangerous Doses. In it, you followed the trail of counterfeit medicine here in the U.S. and the gray market that permits the sale of expired or fraudulent drugs. And then you contacted us about an antidepressant called Wellbutrin and a generic called Budeprion, and that led to an article in Self magazine called Bad Bargain. And now you have written an extraordinary book about the generic drug industry. How did you get interested in this topic?
Well, actually, Joe, you were the one who got me interested in this. It was 2008, and I remember it because I've kept my notes. And you called me because patients were calling into your radio program and you're writing into your website with complaints about side effects from generic drugs. And, you know, your question, the complaint seemed credible to you, and your question was, what's wrong with the drugs? And when you couldn't get a satisfactory answer from the FDA, if I recall correctly, you contacted me, and that was really the question that stuck in my mind. What's wrong with the drugs? And that's where my reporting on the generic drug industry began.
Well, I have to apologize because this led you down a rabbit hole. You've been working on this book for a very long time.
That's right. I mean, it's really a global rabbit hole that I went down for a decade to come up with, to write this book. And what was interesting to me is as I was reporting that first article for Self magazine, and I was trying to figure out, well, what were the patients experiencing? What were the doctors experiencing? And the doctors were confounded. They didn't have data. They didn't know what was going on, but a number of them observed that it was difficult to stabilize some of their patients who'd been switched from a brand to generic or between different generic versions. the FDA's position was somewhat, well, it's sort of a psychological reaction to being switched to a new drug. But that did not seem really all that credible to me. But as I began to report, I realized, I'm kind of looking in the wrong place here. Because even if I could establish that something is wrong with the drugs and that patients are being harmed, it's not just in their heads, the question is why? And that's really when I began to look at the manufacturing plants that were 7,000 miles away in India and in China, where the majority of our generic drugs are made.
Catherine, how is it that we now import 80% of our medications from overseas? At one time, back in the old-fashioned 20th century, pretty much most of our medicine was made here in the U.S.
It's really something that has happened sort of gradually at first and then all at once. So starting in the early 2000s, companies were moving manufacturing overseas where they figured out that they could cut costs and increase profits dramatically, almost overnight. Cost of labor was lower, cost of supplies was lower, and also they didn't have all of those environmental regulations. There's a lot of waste product in manufacturing of pharmaceuticals. So, not only was there an exodus of Western companies moving manufacturing to India and China, but also there was the rise of Indian generic companies, which were supplying AIDS drugs to Africa and then basically got into our market as well.
Perhaps before we go any further, we had best define a generic drug. What are generic drugs?
So generic drugs are a legally manufactured version of a brand name drug that has gained approval from the FDA and usually is brought to market after the result of a legal battle over a patent or after a patent lapses. And those drugs, the generics, are not an identical version. They're an approximate version.
Well, hang on just a sec, Catherine, because for years, the FDA maintained that generic drugs were, in fact, identical. That was the word they used. Now, they've modified that a little bit.
When Joe pinned them down, they changed their definition.
They changed the definition. So what is a generic in the sense of, what do they put in there? And how do they figure out the recipe? Because I think a lot of physicians and pharmacists and nurses and patients believe, the brand name company just gives the FDA the formula, the recipe, the details, and then anybody can copy it.
Right. And that really is a big misunderstanding, the idea that somehow there is an amicable handover of intellectual property in order to make the best drug possible. Whereas, in fact, chemists who are called reverse engineers, who work for the generic companies, have to break down an existing brand name drug in a laboratory and figure out how to re-engineer it from the ground up. And they often have to do that using different excipients, which are additional ingredients. There may be a different time-release mechanism for time-release drugs. They have to use the same active ingredient, but in fact, the final drug product is going to fall within a range that the FDA has deemed to be bioequivalent, which is the absorption into the blood of the active ingredient. And that range can be anywhere from 20%, I think is it 20% below or 15%, 25% above the target of the brand name drug. So there can be a range of absorption into the bloodstream of a generic.
Now, the idea of the timed release really it came to our attention while we were looking at the question of budepion versus Wellbutrin. And we discovered that Wellbutrin had not just one patent, but a couple of patents, maybe more than 2 or 3. At least one of which continued after the active pharmaceutical ingredient, bupropion, went off patent. They still had an active patent being held for the time release part. And that was what Teva, making budeprion, had such a difficult time trying to match.
Right. And those, doctors who prescribe what are called narrow therapeutic index drugs, so those are drugs that require precise dosing, contend that, differences in some of these drugs are really clinically significant. That, patients who require precise dosing for, neurology issues, mental health issues, cardiac issues, thyroid issues, that those patients are really getting a different clinical experience and response from these differently manufactured drugs.
We're going to dive into the research that you put into this extraordinary book. But first, you're talking about narrow therapeutic index drugs, and you've had some interactions with people at the Cleveland Clinic, especially when it comes to rejection of an organ transplant. Can you tell us briefly what that was about?
Well, this is really an extraordinary story. So the pharmacists at the Cleveland Clinic, who are really very vigilant and run essentially a sort of mini FDA to try to figure out what drugs the health system should carry and what they shouldn't, had decided that they were concerned about a drug called tacrolimus made by Dr. Reddy's, and that's an immunosuppressant that every transplant patient must take. And they were concerned because of the number of recalls, so they told the hospital, they told the physicians, we're not carrying this version of the drug anymore. Lo and behold, once those patients left the hospital, went to their pharmacies, they were getting switched to this Dr. Reddy's tacrolimus. Several of them wound up back in the emergency room with symptoms of organ rejection, and a doctor named Randall Starling, who is a transplant physician and takes care of these patients, was really alarmed, finding that, you go through $1 million organ heart transplant, you put these patients on a lifetime drug immunosuppressant that is a critical medication. Then at a CVS pharmacy, they're getting switched to a low-cost generic, and they're back in the emergency room and the ICU with symptoms of organ rejection. And in fact, one of those patients, a 35-year-old woman named Christy Jordan, died. She never really recovered her health.
You are listening to investigative journalist Katherine Eban, a Fortune magazine contributor and Andrew Carnegie Fellow. She's the author of Dangerous Doses, a true story of cops, counterfeiters, and the contamination of America's drug supply, and lectures frequently on the topic of pharmaceutical integrity. Her most recent book is Bottle of Lies, the inside story of the generic drug boom.
After the break, we'll find out about companies fabricating quality control data.
Why do drug manufacturers rush to be the first one to market a generic formulation of a popular brand name drug?
We'll also find out what it's like to be a whistleblower and tell the FDA about the fraud and cover-ups you've observed.
How did the FDA react to Dinesh Thakur's reports?
We'll also find out how Katherine Eban was able to find out what's going on behind the scenes at generic drug plants.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Grayton. If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1169. That number again, 800-732-2334, or visit our website, peoplespharmacy.com. You can also download the free podcast from iTunes.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
We're talking today about generic drugs and how the FDA oversees them. How well does the agency monitor manufacturers in places like India, China, Thailand, or Slovakia?
Our guest is Catherine Eban, an investigative journalist, a contributor to Fortune magazine, and an Andrew Carnegie Fellow. Her new book is Bottle of Lies, the inside story of the generic drug boom.
Catherine, the idea that a patient could die because a generic drug was not up to standard is just, I think, very shocking for most of us to even imagine possible. And yet, these drugs that you're talking about that were being tested at the Cleveland Clinic demonstrated that this Indian company, Dr. Reddy, was perhaps not doing their due diligence when it came to manufacturing this immune-suppressing drug?
Well, it's really worse than not doing their due diligence. In fact, the FDA investigators have found that Dr. Reddy's, along with numerous other generic drug companies overseas, are fabricating their quality data, which basically means that the drug that they're getting approval to make is not necessarily the one they're claiming it is. Now, the FDA contends, well, when a drug first launches, then we get a lot of patient complaints because it looks different and it's a different color and patients react, which is essentially it's in their head claim. Whereas in my reporting, in fact, in a rush to be the first to market with a drug in the U.S., companies would fabricate data, meaning they don't actually know how to make the drug. They'll get approval to make the drug, and then while they're literally selling it, they'll go back and try to figure out how to make it.
Catherine, what is the rush to be first to market? Normally, for a generic drug, there may be, several manufacturers of a drug like metoprolol, for example.
Right. Well, the architects of legislation called the Hatch-Waxman Act in 1984, which really launched the generic drug industry, created an incentive for generic companies. It went like this. It was called First to File. It said the first generic drug company to submit its application to the FDA and get approval is going to have 6 months of exclusivity on the market. And in that time, they can probably charge about 80% of the brand name price. That ignited the generic drug industry to the extent that the race to be first was so intense. You had generic drug companies sending their executives in limos to camp out in the FDA parking lot in order to be first through the door in the morning.
Now, if the FDA investigators have actually discovered that the data on quality are being fabricated, don't they come down like a ton of bricks on these companies?
Well, this was another extraordinary part of my reporting, which is sometimes they do, and there were yet numerous occasions where the FDA would end up downgrading the investigators' recommendations. So, therefore, the plant or a company in question would evade sanctions or stricter regulatory limits. Now, why were they doing that? There really is no plan B when it comes to our drug supply. The FDA's position is we need all these generics, and they are permitting drugs that their investigators have deemed unsafe to be coming into the U.S.
Yikes. I mean, that is an incredible indictment, Catherine. And I guess it leads us to a very interesting story. We have had the opportunity to interview Dinesh Thakur. and you have devoted a substantial part of the book to him. Can you briefly tell us a little bit about him and what he discovered, and then his relationship to the FDA and why he wasn't immediately recognized as a hero?
Yeah, so he was a young scientist and computer expert who worked at Bristol-Myers Squibb in the U.S., and he was recruited to take a job at India's largest generic drug company, Ranbaxy. And there, his boss, who had also come from a big pharma company, developed suspicions about the quality of Ranbaxy's data and whether, in fact, the company was telling the truth in its filings to regulators around the world. So he gave Dinesh a rather extraordinary assignment to investigate the company's own regulatory filings and see if they were all supported by data or not. So over a period of weeks, Dinesh and his team dug into this, and what they found was really extraordinary, that the company had fabricated data for more than 200 drug products in more than 40 countries. They put this information into a PowerPoint, which was shown to a subcommittee of the board of directors. Basically, their position was, we have to hide this data, we have to destroy the laptop that the PowerPoint was created on. And shortly after that, his boss left the company and Dinesh Thakur was forced out. And it was from that position, having left the company, that he ultimately became an FDA whistleblower.
Now, how did the FDA react to his news?
Well, to give the FDA a little credit here, Dinesh reached out to regulators around the world to sound the alarm. And the FDA was the only one that actually responded. And it began, after a lot of stops and starts, an investigation which revealed, in fact, Dinesh's information was correct. The company was saturated in fraud. It was fabricating its data. It was literally switching out unapproved ingredients into these drugs in the laboratory in secret, and American patients were getting those drugs. And yet, this investigation went on for years, for 8 years, and in the middle of that, the FDA approved one Ranbaxy drug after another, including the biggest generic drug launch in history of generic Lipitor, and Ranbaxy ended up making $600 million from that launch. So, yes, the FDA investigated. Yes, the company was ultimately brought to task, but, U.S. patients got way more Ranbaxy drugs than we should have in that time.
Now, we know that Ranbaxy actually did have to pay a rather significant fine, ultimately, but are there still Ranbaxy drugs on the market in the U.S.?
Well, essentially there are. Ranbaxy was absorbed by a company named Sun Pharma, but Sun Pharma is manufacturing drugs for the U.S. market from Ranbaxy factories, and those are being sold into the U.S. So, yes, the answer is yes.
Now, there was one particular drug that Ranbaxy was working on. Accutane was the brand name, and I think they had a branded generic. Was it called Sotret?
That's right. And this is really a scary story that I expose in the book, which is Ranbaxy executives knew that the drug was failing. It didn't pass dissolution tests. The 40-milligram drug was absolutely terrible in its laboratory tests. And what they needed to do was report all of that to the FDA and pull it off the market. But instead, in a meeting in Boca Raton, the executives decided they were going to keep the drug on the market. They would go back to the laboratory and try to sort of re-engineer it. And meanwhile, U.S. patients were getting that drug.
And this is a very powerful acne medication that has a number of side effects and even, if I'm not mistaken, a black box warning.
That is correct. That drug is really, even under the best of circumstances and made properly, that drug is extremely dangerous and does come with a black box warning. In this case, they were knowingly manufacturing and marketing a substandard drug.
Catherine, can you tell us a little bit about how you went about researching the evidence that you uncovered in Bottle of Lies. I mean, you went to a number of countries, you talked to a number of whistleblowers, you even talked to people who worked for the Food and Drug Administration.
That's right. So basically, in the work of investigative reporting, you are trying to cultivate sources who are often very reluctant. You are trying to get as many documents, internal documents, as you can, because those always tell a story. And at the same time, I was traveling to India, China, Mexico, Ireland, England, Ghana. I traveled really all around the world to report this book. And, there were key breakthroughs along the way. So, for example, one was obtaining about, I estimated, 20,000 internal FDA documents. So these were emails, minutes of meetings, internal reports, and they really tell the story of the FDA's sort of loss of sense of mission, difficulty knowing what to do with these companies that they absolutely knew were flouting regulations and manufacturing dangerous drugs, infighting between prosecutors and regulators, challenges in getting information, kind of a sense of desperation as the number of overseas plants grew. I mean, those documents tell a story that helped me bring the struggles alive in the book. At the same time, key whistleblowers contacted me during the reporting process and helped me get inside several companies. And, I'll never forget a meeting I had with a chemist. I was in India. I was at the Taj Hotel in the Sea Lounge with a beautiful view of the Gateway of India. And this man just crying with tears rolling down his face, telling me the industry is very, very, very dirty.
How did you find those whistleblowers?
In some cases, they found me. In other cases, once I reached into my network of sources, they provided me with names. In other cases, often it was just combing through LinkedIn. Who's a former employee? Who worked in the divisions that I'm looking to penetrate? Who has insight into the quality control laboratories? Sometimes it was following a trail of the 483 observations that the FDA writes up.
Those are the warning letters that they send out to the drug companies.
That's right. Sometimes it's through legal records and litigation. There's a whole number of ways that you can sort of reach into a company and try to extract, information, try to find people who know. In other cases, some of those internal FDA documents led me to whistleblowers who had already contacted the FDA.
Now, you got a message from somebody by the name of $4 Refill, presumably, being able to go to a big box pharmacy and get a month's supply of generic drugs for $4.
That's right. I got this anonymous email from $4 Refill, and basically that source was telling me to look overseas. That source was telling me that the way these overseas generic companies were operating was to minimize cost and maximize profits by any means possible, which meant being first to market even if you didn't know how to make the drug, altering laboratory tests so that failing drugs passed specifications, switching out proper approved active ingredients with low-cost ingredients, using the brand name drugs instead of your own drugs to test and create data from. So, there were any number of sort of deceit and subterfuge that these companies were using to game the regulatory system and increase their profits.
Catherine, you talked to a man named Peter Baker who was working for the FDA. Can you tell us a bit about his story?
So Peter Baker was a young FDA investigator who had volunteered to go overseas and relocate to India when, frankly, many FDA investigators didn't want to be there. But he was young, he was adventurous, But he also had another reason for volunteering, which was by reputation, India is one of the world's leaders in aseptic manufacturing, which is the very sort of grueling scientific process of sterile manufacturing. So he volunteered, and he, through his own sort of keen observation and also through looking in the company's computer systems, he began to realize that many of these companies, which looked absolutely perfect from the outside, inside were running these hidden laboratory operations in which they were fabricating data.
Pretty extraordinary. And how did the FDA deal with its employee, Peter Baker, and did he go beyond India to any other countries?
Well, he did. After he was posted in India, where I must say, I mean, his story is very dramatic. He endured really remarkable conditions. He and his colleagues were poisoned with adulterated tap water in these plants, which sickened them and reduced their inspection time. He was followed. In one instance, their hotel room was bugged from a company trying to get observations into what they were finding. You know, and one thing to make clear is that critical FDA findings are huge money-losing issues for these companies. So, for example, one company, Wockhardt, where he was able to find fraud, and he detected it from these torn records that he found in a garbage bag. That company, because of his observations, lost $100 million because the FDA put an import alert on the company. So, you know, he was really in many ways a mortal threat to these companies. But after he went to India, then he went to China, and using even college-level Mandarin, was able to detect the same kind of fraud and deception. So by my count, over the course of 5 years, 86 inspections in India and China, he found fraud or deceptive data practices in about 67 of those. Basically 4/5 of the companies he went into, he found this. Now, that is a disaster for the FDA because these findings require the FDA to slap these companies with restrictions, import alerts, warning letters. So I think the question for the agency is, are we going to have any drugs left if we restrict all these drugs?
You're listening to Katherine Eban, an investigative journalist and Andrew Carnegie Fellow. She's the author of Dangerous Doses, a true story of cops, counterfeiters, and the contamination of America's drug supply. We're talking about her most recent book, Bottle of Lies, the inside story of the generic drug boom.
And her name, Eban, is spelled E-B-A-N. After the break, we'll talk about the drug shortages that are occurring because of ARB drugs like losartan and valsartan. They had to be recalled.
Do generic manufacturers get to keep making their medicines even while they're under investigation?
Learn about the FDA's pilot program to do surprise plant inspections overseas.
What recourse do consumers have if they don't want to take inferior quality generic drugs?
Most medicines nowadays are generic. Where do they come from?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase P-E-O-P-L-E. To learn more, go to Verisana.com. That's Verisana.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1169. That number again, 800-732-2334, or you can find it at peoplespharmacy.com. You can also download the free podcast from iTunes or from our web store. We invite you to consider writing a review.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Have you ever had a question about your generic drug quality? Is a $4 generic prescription made in China identical to a brand name medicine that sells for over $500? How well does the FDA scrutinize the manufacture of generic drugs? What can be done to ensure our medicines are of the highest quality?
Our guest is investigative journalist Katherine Eban. She's a Fortune magazine contributor and Andrew Carnegie Fellow. Ms. Eban is the author of Dangerous Doses, a true story of cops, counterfeiters, and the contamination of America's drug supply, and she lectures frequently on the topic of pharmaceutical integrity. Her most recent book is Bottle of Lies, the inside story of the generic drug boom.
Katherine, there have been so many problems in the generic drug industry, especially of late, based on some ingredients made in China and India that literally millions, tens of millions of pills have been pulled off the market. These are what we call ARBs, angiotensin receptor blocker blood pressure drugs like losartan, valsartan, irbesartan, that there have been huge shortages. And this has created some problems for the Food and Drug Administration.
Enormous problems. I mean, basically, the way that the FDA has responded to these kinds of crises is to wait until they're sort of overrun with it, then restrict the drugs in question. Then there are drug shortages, and the drug shortages create another opportunity for companies that are cutting corners, because if you're making a drug that's in short supply, the FDA is going to overlook a lot of quality issues. So, we've been in this horrible merry-go-round of quality crises, restrictions by the FDA, drug shortages, and green lights for companies that are not really compliant fully with regulations.
Well, when you said, here was Ranbaxy, this very large Indian generic drug company, in all kinds of trouble because a whistleblower had revealed what they were doing, and they had this application into the Food and Drug Administration to be able to market Lipitor, the most successful drug probably in the history of the world.
Technically, they were marketing atorvastatin, right, Joe?
The generic version of Lipitor. And the FDA says, okay, even though they were under investigation. I just don't get it.
And it's even worse than that. I mean, one of the things that I expose in the book is that at the last minute, before they were going to green light that application, they realized they hadn't done a pre-approval inspection at the manufacturing plant where Ranbaxy was going to make the active ingredient, a plant called Tawansa. So last minute, they send an inspector there, Regina Brown. She investigates, and she finds terrible conditions. She finds a shredder in the middle of the manufacturing floor, which is a bad sign that there is data fabrication and destruction of documents. She found all kinds of good manufacturing practice violations. And so she deemed the plant to be what's called official action indicated, which is a pretty serious sanction. It basically says you have critical problems here. You have to fix them immediately. Well, that left the FDA with a problem because they had 24 hours to green light this atorvastatin that millions of Americans were waiting to take. So what they did is they downgraded her findings from OAI, official action indicated, to voluntary action indicated, which basically allowed Ranbaxy to make the drug. And within a year, it was then disclosed that all of this atorvastatin Ranbaxy was making was saturated with glass particles and had to be recalled from the market.
Oops.
That is shocking. Catherine, of all the shocking things that you have discovered in the course of your investigation, what shocked you most?
When you're reporting and so many details come up, you capture all these details. I think the detail that shocked me most, perhaps, was that once the FDA did this limited trial, they called it a pilot program, where for a year and a half, from 2014 through mid-2015, they did unannounced inspections in India, and we should really talk about that issue. They gave these plants either no notice or very short notice that they were coming. Once they did that, and once they walked in unannounced, they realized that several of these companies were even fabricating their own sterility data, proving that the plant was sterile. These plants have to do environmental monitoring of their air, of their water. They do swabs of surfaces to make sure there's no microbial growth, contamination. These plants were faking so much data that they were even faking that data. That's how rotten, that's how much deception there is in these plants. I think it tells you something.
Well, it suggests that fabricating data was an intrinsic part of the culture in these manufacturing plants. Tell us then, why was this pilot program so important?
Okay, so there's a critical difference between domestic inspections and overseas inspections. In domestic inspections, FDA investigators show up at a plant unannounced and stay as long as they need, which is obviously the way to do it. But overseas, the FDA made a different decision based on the difficult logistics. They have announced their inspections weeks and sometimes months in advance. And this has given these plants an opportunity to stage the inspections. I've discovered that some of these plants operate data fabrication teams that come in before the FDA and just alter and invent documents. So the reason the pilot program was critical is that it was a sort of test run of what it would be like to do unannounced inspections. And once they started doing that, the rate of the most severe finding increased by almost 60%. So that really tells you that, the FDA is finding terrible stuff, but they're not finding nearly as much terrible stuff as they would if they did unannounced inspections. And during those unannounced inspections, they found bird infestations. Think of all these, sterile solvents and bird droppings. They found fake sterility data. They found evidence that these data fabrication teams were operating. So you would say, why wouldn't the FDA make this the way every overseas inspection would operate? But instead, the
why
FDA,
not?
Why not? The FDA canceled the pilot program. They offered no explanation for that, and now they have gone back to pre-announced inspections overseas.
What?
Yeah.
Hold it. That makes no sense whatsoever, Catherine, because what you have just said is it was working. That the unannounced...
Right.
Look, if you're making generic drugs in China or Thailand or Brazil or India or Mexico, and you want to export those medications to the United States, presumably we get to tell them what the rules are. We get to investigate your plants unannounced. But they canceled it.
You would think that would be the way it worked. Yes, that is the way it should work.
Why
but instead,
did the FDA have any explanation for why they canceled this pilot program?
I spent a long time reporting this. I wanted to see, was there pressure from the State Department? I FOIA'd the State Department. I asked for documents from the State Department. I could never really figure out an answer. But I do have a belief, which is that the results of the pilot program were so troubling and the consequences would be so grave, as in putting an import alert on so many plants and so many drugs, that the FDA actually does not want to know what is really going on in these plants.
Okay, so is the FDA making a decision that it's better to have enough drugs, even if they're not good drugs, than it is to block inferior quality drugs from coming into the American market?
I think there is some evidence to support that, and I'll tell you what it is, which is another thing that I found is over the course of 6 years, from 2012 to 2018, the FDA downgraded the findings of its own investigators at Indian plants 110 times. In the U.S., same time period, the number of downgrades was 1.
Whoa.
Why all the downgrades? Why are they reducing the regulatory sanctions on these plants? The regulatory sanctions would have restricted the drugs from coming into the U.S. market. The downgrades meant those restrictions were lifted and the plant was free to export its drugs to the U.S.
So, Catherine, listeners are undoubtedly feeling, as I am right now, I don't want to take inferior quality drugs, and yet I have no choice in many situations. If I'm going to take a medication, I have to take a generic medication. I can't afford the brand name. What can we do to protect ourselves? How can we change this situation?
And let's remember, how many of our drugs are generic now? It's my understanding that it may be over 90%.
Yeah. 90% of our drug supply is generic, and the majority of those drugs are coming from overseas plants. So, look, we need laws changed. We need a congressional investigation, and we need laws changed. But let's just start with, at this moment, what can a consumer do? So the first thing is, if you're on a maintenance medication, what I think is important is to know who the manufacturer is. And to try to figure out, is your drug working? Do you feel strange side effects? If your drug is working, then you want to know the manufacturer so you can stay on it, so you don't get switched to another generic manufacturer the next time you go to the pharmacy. But if the drug isn't working, then you need to know, well, what other manufacturers make the drug? So obviously you can ask that question to your pharmacist. You can also look in the FDA Orange Book. And I'm actually about to put some of these guideposts for consumers up on my website. You can go to the FDA Orange Book. Another thing you can do, go into Google, put in FDA warning letter and the name of the drug manufacturer. See what the FDA has found in their plants.
You know, it's so interesting when you look up these generic manufacturers, you kind of make assumptions about where they're located. Like Wockhardt kind of sounds like it might be maybe a German company. You have no idea about what Sun Pharmaceutical is. It's important to know where these companies are located and, as you point out, if they've gotten warning letters.
Well, this is another real problem, which is there is so little transparency for consumers about where their drugs are made. So, you know, if you go to Whole Foods and you can find out that your apple came from California or Chile, right? If you buy a shirt, you know what country it was manufactured in. But we don't know from the dispensing label where our drug or drug ingredients are made, and that really needs to change. I think it's critical that consumers have that information, and frankly, I think it could have a powerful effect because I think most consumers would rather take a drug manufactured in the USA than take one manufactured in India. And that's no offense to India, but obviously there is a lot that can go wrong in a globalized drug supply. I don't know if you saw the most recent warning letter to an Indian plant where they found fabricated data and ripped up documents in a garbage bag and all kinds of unsanitary conditions. And the plant's explanation to FDA investigators is that its staff was out for a 9-day Indian dancing festival and weren't able to perform the necessary functions inside the manufacturing plant. I mean, there are really a lot of issues once you get into a globalized drug supply. And I think we need, as a country, to be manufacturing some of our own basic drugs. I mean, you basically can't even find an antibiotic that's manufactured in this country anymore.
Now, of course, they will be more expensive, right?
Well, here is a role for Congress, which is to find a way to meaningfully regulate drug prices. I mean, I see a connection between the ever-climbing drug prices on the brand side and the fact that we have been sort of forced into the arms of the lowest cost providers overseas. What if you could meaningfully regulate drug prices? I mean, it's interesting. This is definitely going to be a 2020 issue. Elizabeth Warren has a proposal to have the U.S. government manufacture generic drugs as a way to deal with the crisis of costs.
And presumably, if we want country of origin labeling on our medications, that's also something that requires congressional action, right?
Absolutely. I mean, there is no way to fix some of the problems that I exposed without congressional action.
I guess in wrapping up, Catherine, I think back to Upton Sinclair in the jungle and meat packing plants and the absolute outrage by the American public and Congress as a result of his revelations. Do you think that your book, Bottle of Lies, the inside story of the generic drug boom, might stimulate a similar outrage on the part of the public and Congress and people who make decisions about our medicines?
I'd like to think so. I mean, some reviewers have compared this to a 21st century version of The Jungle. And I think if your listeners read the book and respond to their elected officials, we really need a consumer revolution here that is based on knowledge and information about what is happening in these plants.
Catherine Eban, thank you so much for talking with us on the People's Pharmacy today.
It's been a real pleasure. Thank you.
You've been listening to Catherine Eban, E-B-A-N. She's an investigative journalist, a contributor to Fortune magazine, and an Andrew Carnegie Fellow. She's author of Dangerous Doses and her new book, Bottle of Lies, the inside story of the generic drug boom. And you may also want to take a look at the book The Jungle by Upton Sinclair about the meatpacking industry and see the parallels.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome online at verisana.com.
If you'd like to buy a CD of today's show or any other People's Pharmacy episode, you can call 800-732-2334. Today's show is number 1169. That number again, 800-732-2334. You can also place your order online at peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Have you ever had questions about generic drug quality? How has your doctor or pharmacist responded? You may want to read Bottle of Lies and share it with your health professionals or your insurance company.
And when you go to the website, peoplespharmacy.com, you will find a link to Catherine Eban's website. You can sign up for our free online newsletter or subscribe to the free podcast.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.